talked a little bit in the last video about the fact that it can be very easy to jump to conclusions and see everything in the world as a mental health disorder after taking a course such as this. And really we need to step back and take a look at the entire life of an individual, their psychosocial milieu, and understand that not everything that is diagnosed by a mental health clinician is a disorder. Sometimes when people come in the door, what they actually have is what is clinically referred to as a problem. So problems are transient and they're culturally expected responses to interpersonal issues. For example, a person might have relational problems such as a marital or parenting issue, or they might have a socioeconomic issue such as a job loss or a transition in their housing, particularly if that housing transition is not a planned or desired one. And these are normally addressed by supporting the person in their psychosocial category. As opposed to giving them mental health support, we would emphasize more the support that we provide for that individual outside of the medical realm. And the resulting stress of these problems, if they aren't addressed early on, can indeed lead to a mental health issue. So we want to deal with these issues at their source early on if we possibly can, because later on they can manifest as serious mental health issues. And let's take a look at a couple of cases to wrap up this module that will help us to illustrate some of this. So these are based loosely on sort of an amalgamation of real cases. The first case is we're going to be calling it Miss Violet. She's a 74-year-old woman who lives alone. She's a widow. And her behavior is that she calls the police, the mayor, and public works 3 to 4 times weekly, sometimes more often than that. And when she does, typically she complains about teenagers and vandalism. And sometimes she complains that others that she's spoken to haven't given her an adequate response. But whenever anybody goes out and actually takes a look at her vehicle or her property, there's really rarely any evidence that anybody has done any kind of vandalism against her at all. And she's often identified that a particular group of youth, a particular neighbor, has been the issue. But when the police go and investigate, they have simply not found much to support what she's alleging. When she calls, she tends to stay on the phone for an extended period of time, 30 to 45 minutes, and she asks for people to come and meet with her. So it's not just that she wants to be on the telephone, but she consistently wants people to come to her property and have a longer conversation with her, or come and take a look at her shed, or come and take a look at her van and see exactly what is going on. Now, in these conversations, she is having a lucid and fluid conversation. She tends to be telling a story at length, but she isn't repeating herself or forgetting what people have said. Our second case is somebody we'll call Miss Q, no pun intended. She's a 37-year-old woman and she lives alone as well. She is single. She's never been married. She calls police daily and often actually calls the police multiple times in a day. And when she calls and speaks to one officer or one person at 911, she will often actually follow up by phoning the non-emergency number, and then from there speaking additionally to people who are at a supervisory level in the police department, often complaining that she hasn't got a satisfactory response from the people earlier in the day. She tends to stay on the phone as well for an extended period of time, roughly 30 minutes at a time, and she often repeats the same things over and over again, seemingly forgetting what we've already talked about or simply unprepared to absorb what's being talked about. She has a great deal of focus on herself and has a very difficult time relating to the needs of others in the community, and she gets very, very angry as these conversations ensue, and yet when she calls back the next day, it seems as though she has started from a blank slate. She has a major conflict in particular with one neighbor and complains a great deal about illicit behavior, but again there is little evidence of this. There is evidence that she has actually begun to trespass on the individual's property, both to investigate his behavior as well as potentially to do some kind of retribution. And she's in fact threatening to poison her neighbor's cats for coming on her property. So the questions we want to ask you about these two relatively similar cases are either of these scenarios dangerous or potentially dangerous? Does either scenario potentially involve a psychiatric disorder, and if so, what evidence suggests this? Notice that the question is not asking you to assess what psychiatric disorder, but whether or not there's a threshold here where you might try to get a person involved with a psychiatric professional, or what other types of supports you might try to bring to bear. And what might you do to resolve these matters is what the last question is. Take a moment and write your answers, and again, review what others have said, and feel free to respond to others or augment your answer with the ideas people have built in.